Continuing on with chapter 16, talking about history taking. So obviously history taking is the same with anything else. We're investigating the chief complaint. Some specific questions that you're going to want to ask patients that are experiencing issues that could be cardiovascular in nature. If the patient's experiencing dyspnea, is it due to exertion or does it change when you change positions? Is it continuous or does it change? For example, if you take a deep breath, does that change your pain? If I press on your chest, does that change your pain at all? If the patient has a cough, does it produce sputum? If so, is there a color to it? And then ask if they have any nausea and vomiting, fatigue, headache, and or palpitations. Palpitations are when your heart's fluttering, kind of feels like it's going to beat out of your chest. And then ask about any recent trauma as well. You're going to get a sample. For sure, use OPQRST to get more information. More questions. Have you ever had a heart attack? Have you been told that you have heart problems? Do you have any risks for coronary artery disease? And you're going to say that, and they're going to kind of look at you. So ask them about some of your risk factors. Do you smoke? Do you have high cholesterol? Do you have high blood pressure? Those types of things are going to be more pertinent to that patient. And then we're going to move on to the secondary assessment. So you're going to focus obviously on the cardiac and respiratory systems. We're going to reassess pulses, but at various locations, see if it's symmetrical in the arms, see if there's any changes in the legs, any differences in skin temperature or the actual color, respirations, looking for distended neck veins, known as JVD. Is the trachea deviated or is it midline? Remember, for that, we're checking at that suprasternal notch, not clear up at the thyroid cartilage. And then you're going to go ahead and get a full set of vitals to make sure that you have that baseline. And then if you have the availability, you may want to take a 12 lead EKG. You can, as EMTs, assist with the placement of the electrodes. There are initiatives that allow EMTs to take and transmit 12 lead EKGs. You guys can't interpret them, but you can certainly send them on for interpretation by the hospital. Reassessment. With somebody that's having chest pain, we want to reassess them every 5 minutes, even if they're relatively stable, just because we want to try and catch any significant changes within their condition. With somebody that's experiencing chest pain that could be related to an AMI, sudden cardiac arrest is always a risk. If that happens, CPR and then utilize an AED as soon as possible. Make sure you're reassessing your interventions, provide transport, and then alert the emergency department about the patient's condition, estimated time of arrival. There may be additional reporting that you have to do, kind of depends on your system, if you have a STEMI alert or not. So just keep that in mind. Emergency medical care for chest pain or comfort. So the acronym that we use is MONA. You guys can't give the M, which is morphine, but you can do oxygen. You can do low-dose aspirin, and you can assist with their prescribed nitroglycerin. You want to try and keep patients as comfortable as possible, loosen any tight clothing, give oxygen if indicated. You want to titrate oxygen so that it's sitting between 95 and 99. We don't want to try and push patients up to 100, especially if they're not perfusing their heart. You're going to build up a lot of oxygen-free radicals, which can then cause reperfusion injuries. So 95 to 99 is perfectly acceptable. Medications here, aspirin. The point of aspirin, which we've talked about before, is that it prevents clots from either forming or getting bigger because it inhibits platelet aggregation. You're going to use the low dose aspirin, which are the 81 milligram tablets. Recommended dose is 2 to 4. Typically, we just go ahead and go with the 324 milligrams, so the 4 tablets, and they chew them, and it is nasty. So just prepare them for that. Nitroglycerin, there's a couple different available forms. You've got the sublingual pill, the sublingual spray, and then either the patch or paste that's applied to the chest. Remember, again, this relaxes the walls of blood vessels to increase blood flow and oxygen supply to the heart. It decreases the workload of the heart by dilating those blood vessels. It will more than likely cause that severe headache, and it can cause a significant change in their blood pressure. So make sure that you take their blood pressure before. If it's less than 100, we're not systolically, we're not giving nitroglycerin. After that, we want to check again to make sure that we're not bottoming out their blood pressure. If they've had a head injury, we're not giving nitroglycerin to somebody. Make sure that you ask both men and women about their use of erectile dysfunction drugs, because both sexes use them, and not necessarily obviously just for erectile dysfunction. The maximum prescribed dose is generally 3 doses. So they're 0.4 a piece, so 1.2 milligrams is generally the max dose. If the patient has already taken that, you need to contact medical control. When administering, make sure that it's not expired or contaminated. If it has been kept out in the sun, it's probably not going to work. So just double check with your patient and wear gloves when you administer that medication. It absorbs very readily. So cardiac monitoring, we can go ahead and hook up typically a 4 lead. Nowadays, there's not very many services that run with a 3 lead anymore. In order to be reliable, you have to be consistent with your placement of electrodes. It does say on them where you place them, and you should go through a familiarization type session with your system so that you know where you should be placing these electrodes. There's some guiding principles that you need to follow to achieve the best skin contact and to minimize artifact. Artifact is any deviation from the baseline that is not created from the heart itself. So you very well may need to shave body hair. If you can't put the electrode directly to the skin, that's a problem. There is the possibility that you might need to rub the site with an alcohol swab before application. On some of the electrodes, there's a kind of rough blue strip on the back of the paper, and that's to buff the skin to make it so that the electrodes stick a little bit better. You want to attach the electrodes to the cables before placement, because then you're not forcing that cable into the patient's skin. So attach everything before, and then put all of the electrodes in place, switch on the monitor, and print a sample rhythm strip to make sure that you don't have a bunch of artifact. If you have a bunch of artifact, go ahead and press more firmly. Here's where we're placing the different electrodes. The one on the left is your 4 lead. The one on the right is your 12 lead. So for a 4 lead, the way to remember is white on right, smoke over fire, clouds over grass. So your white one is going to go on that right shoulder, and we're trying not to put these over bony prominences. You want to try and keep it over muscle. So white on that right shoulder, black on the left shoulder, green on the right lower abdomen, hip area, and then red on the left. Some do recommend putting it down on the lower leg, but this is a good starting point for you in putting those electrodes on. When you're putting on a 12 lead, yes, I know it says that there's 12 leads. However, you're only going to have 10 on the skin. you do have some what are called augmented leads that are based on that fourth original that you've placed. So your V1 is that fourth intercostal space on the right sternal border. And yes, you actually have to feel down. Keep in mind, you can't actually feel that first rib because it's tucked behind your clavicle or your collarbone. So your collarbone is just going to be your count as 1, and you're going to go all the way down into that fourth intercostal space, and you want it in the space, not over top of the rib. Place it there on the right side. You're going to place V2 on the left side in the exact same spot. Then you go down. It's really a lot easier to place your V4 first. You're going to go down a space into the fifth intercostal space at the mid-clavicular line. So if you were to divide your clavicle in half, run that all the way down to the fifth intercostal space, go ahead and place that there. Then you can place your V3 in between those two, the V2 and the V4. Your V6 then is at the mid-axillary line, still in that fifth intercostal space. And then you put V5 in between the two, in between V4 and V6. Just go ahead and put that 5 in between there. And then you can go ahead and run your 12 lead or your 4 lead, depending on what's appropriate. Once the electrodes are in place, like I said, go ahead and switch on and print a strip to see what it looks like. You can look on the monitor to see if you're getting a bunch of artifact. The patient should just breathe normally and calmly. If they're shivering, that's going to create a lot of artifact because their muscles are going to get picked up. So you may not be able to get a really good tracing there. Heart surgeries and cardiac assistive devices, really hundreds of thousands of open heart surgeries have been performed. Cardiac bypass, they actually take a little piece of an artery and graft it from one spot in the heart to the other to try and bypass somewhere that's obstructed. It's pretty amazing what they can do now. Percutaneous transluminal coronary angioplasty is something else that they're going to do. This is typically step number 1 for reopening a vessel that's causing a heart attack. So they have a tiny balloon that's attached to the end of a very long, thin tube. They go through either an artery within your wrist or they go through your femoral artery and snake that all the way up to the blockage in the heart. And then they inflate that balloon and then deflate it and remove it. Sometimes they end up placing a stent in there as well to keep it open so that it doesn't just reclose right away. Patients that have had a bypass procedure typically have a pretty long scar on their chest. They may or may not, but that's something to definitely be cognizant of. We want to treat patients who's had any of the procedures as the same as a patient that's never had a heart surgery. It might be kind of shocking to you when you're trying to place leads and they have this massive scar. We still need to treat them the same way. Other patients might have implanted cardiac pacemakers. Pacemakers help maintain a regular cardiac rhythm and rate. They monitor the heart and shock it as necessary. There's actually wires that are placed into the heart with an electrode on it. And it is going to deliver an electrical impulse when it senses preset conditions. They're battery operated and oftentimes have to be replaced. They're about the size of a silver dollar and placed under the skin. They try and put them on that left side, but sometimes they have to put them over on the right. Typically, we don't need to worry about them. They're pretty reliable. They do what they're supposed to. When they don't function properly is when we're going to get called. They might have syncope, dizziness, or weakness due to an excessively slow heart rate that their pacemaker's not picking up. And so then we end up having to take them over. Keep in mind, AED patches should never be placed directly over the pacemaker. And we'll continue in the next video.